Thank you. Good morning, everyone. And I apologise for not being on screen, but I'm having a few issues with my laptop, which has just been rebooted. If and when I manage to get into Zoom, you'll be able to see me as well as hear me. I'm Councillor Graham Bridgeman. I chair the Health and Wellbeing Board, and welcome one and all. We have members in the chamber in Newbury and other members joining us by Zoom, and of course the public are very welcome to watch us on YouTube live or back. In the chamber in Newbury, I am joined by Councillors Lynn Doherty, Martha Stewart, I do apologise, Martha Vickers, Joe Stewart, Steve Masters. Yes, I'm turning you into a...
It's good to see Martha's out of prison.
Turning you into an American legend, Martha. And thankfully, I've got Joe Reeves, which makes us Cora. Well done, Joe. From the ICB now, formerly of the CCG, now changed titles. Other members joining us virtually, I trust, are or will be or should be Dr. Zia Kahir, Professor Tracy Daskovitz, Jessica Jundo Evans, Gail Muirhead, Dr. Janet Lippett, Andy Sharp, Andrew Sharp, Reva Stewart, and Councillor Rick Jones. Also going to welcome Matthew Tate, who will be providing an update from the ICB, and Dr. Joel Malimba and Pooja Patel from Healthy Dialogues, and we'll be dealing with the pharmaceutical needs assessment item. As I said, we're being live streamed, and in the chamber we have Gordon Oliver clerking the meeting and Tom Dunn as Zoom host. Now, because of the formalities of the meeting, only the members, if we do have to take a vote, only the members in the chamber will be able to actually vote on the item, but I will, if I think it fit, take an indicative vote of everybody, both in the room and via Zoom, using Zoom hands, if you would, members zooming in, to see what the flavour of the vote is before we go to the meeting. The other thing is, of course, this is Thursday. We are in Market Street, and Thursday at 10 o'clock means fire and lockdown alarms. So if we are talking in the meeting and something starts ringing at us, we may have to mute and stay silent for a little while when it passes. Okay, so Gordon, have we had apologies for this meeting?
Yes, Chairman. Councillor Dominic Bowick has given us apologies, and Councillor Rick Jones is substituting. Matthew Hensby, Sean Murphy and Gary Poulsen have also given their apologies, and Superintendent Zahid Aziz and Andy Sharp have indicated that they will join later in the meeting.
Okay, fine. Now I've managed to get into Zoom, and all I've got to do is work my way through renaming myself and turning my camera on. In the meantime, let's not hang around. So the first item on the agenda, members, for those of you who are there, are the minutes of the meeting held on Thursday, 19th of May. Are there any amendments? Councillor Vickers.
It's not an amendment.
Would you use your microphone?
Sorry, Chair. It's not an amendment. It was just a sort of follow-up question. Matters arising.
Well, let's deal with that in a moment. Let's start with the minutes. Is there anybody who has any formal amendments to make to the minutes? I can't see anyone leaping out at me, so I won't go to an indicative vote. I will ask the members in the room to indicate whether they agree the minutes of the last meeting. Yeah, that's unanimous, apart from Joe, who is abstaining because she wasn't there. Okay, fine. Right, Councillor Vickers, would you like to tell us what you wanted to say?
Thank you. It was just a question. Page 19, under the resolutions, E, that the council gives consideration to funding a programme of first aid training in schools and colleges and the wider community. I'm wondering whether there's been any progress on that. Is it too early to say?
Right, who might say? Who? Do you want to?
I don't know whether Sakia has an update. I'm not aware.
At the moment, it's a little bit too early, so I'm happy to provide feedback at the next meeting, and we'll take that forwards as to what the action is, partly because it's summer holidays about to start. It didn't seem the right time to be progressing on this.
Thank you very much.
Thank you both. Right, so actions arising from the meeting. I have notes on two of them, and then I'll see whether any you want to put your Zoom hand down again, Councillor Vickers? Thank you. So on action 191, we need to agree when the response to the Health Watch CAMS report will be provided to the board. Who wants to speak to that? Don't all jump at once. Do you have a view, Gordon? Give us a view, Gordon.
Shall we do a 12-month review or a 6-month review? I don't know if anybody's got any views on that. What would be appropriate?
It depends on the level of work that's needed to go into doing whatever needs to be doing before it comes back, I guess, really. I'm looking for officer guidance, Councillor Vickers, though.
I'm just wondering who's on the working group for that. Isn't there a specific working group that's looking into it?
I don't recall.
No?
No.
No, I understand.
No.
But obviously it's a matter of urgency, so it would be good to have some.
Zakia, have you got a view? Oh, and I'll come to, let me come to Councillor Stewart first, and then I'll come.
Do you want me to raise it at the Mental Health Action Group?
Oh, what a good idea.
So I don't recall if we've got another meeting booked in, obviously sort of summer period, but the next one, I will ask the question there, and perhaps we can come up with an opinion for you.
Fine. Okay. Well, let's park it like that. And Zakia, unless you've got something to add to that.
I would have said it's useful to have an interim review at sort of 6 months with a view to bringing it back at 12 months. But I think if we get an opinion from the mental health subgroup, I think that would be very useful.
Okay, thank you both. We'll take that. And on Action 198, just as an update on the defib piece, it has been agreed apparently in principle that though you remember that we discussed the water safety partnership and various bits of water safety kit that were being put on the water side in various places, and it has been agreed in principle that defibs can be part of that piece, and they're now looking at options including costs, and no doubt we'll have yet further on that in due course. So those are the two items I've got updates on to give verbally. Councillor Masters.
Thank you, Chairman. Just as an aside, with that news about the welcome news about the defibs on the water side safety, obviously with the warm weather, we've had a lot of people using the waters for recreation, especially around the back of Northcroft, and the life belt there has been summarily abused at times. I can report that it is this morning back in its correct place, but it was cast adrift over the weir. So any further announcements that we do as a council, can we reinforce the water safety message and the fact that safety equipment is there to save lives, not for recreational fun and japes?
And regrettably, that is not the only site I'm aware of where precisely the same thing, the same vandalism has taken place. It is appalling that vandals think it quite right to damage, what is could save someone's life. And yes, I absolutely agree. And Gordon, let's take that as an action. Let's see what messaging we can achieve on that front. Very happy to take that one and deal with it. Okay, right. Please.
Yeah, just following up on the comment from Councillor Masters, I also live in the vicinity of Northcroft, and I had lots of issues raised by local residents. And in fact, I've been in touch with the Denise Sales from Substance Misuse, because there's an expression of concern from them about the safety of young people, not just obviously the antisocial behaviour, but swimming and how they need to be engaging with young people, because deaths can occur, not just from the danger of what they hit when they jump in, but the cold, etc. So they are actively doing that. And Denise Sales, when I contacted her, did give me a list of actions that she was proposing to take. She responded immediately. So the officers are treating this as a matter of urgency. And I believe they're sending the fire brigade to some of these locations to actually, which sounds an excellent idea, actually. Some people have suggested the police, which I think is totally inappropriate. And this is a health and wellbeing issue, so I think it's very appropriate to be talking about it here. But I think the fire brigade, with their skills and with their recognition and their, I think even young people look up to them and hopefully listen to them. So I think that's an excellent idea, but I think it's something we should be, keeping tracks on. I was over in Northcroft Field yesterday and saw young people, did speak to them. Some of them were just devil may care, others appreciating what was going on. Lots of litter around, which is another issue, not for this committee. But I do hope the council will keep track of this and that we'll treat it as a health and wellbeing issue and make sure that the resources are there to engage with young people. It's really about talking to them and getting them to understand what's going on and the dangers are.
Councillor Doxey, I suspect you want to come back on that.
Yes, I fear we're in danger of going down lots of different routes because it has been raised over at Pangbourne Meadows, and I've already been talking to the Water Safety Partnership around this, and actually the police as well, because when you talk about criminal damage, which is criminal damage when you start to throw brand new equipment into the water, then I think it needs a multi-agency response, not just one agency. So what I would ask, Chairman, is that we actually tie all these pieces together rather than all going off and doing our own thing. And I know that I've already spoken to the environmental health team and the water safety partnership team and the countryside team around some of this work. So I think it's a multi-agency response that is required across West Berkshire, so not just Northcroft, because I know Pangbourne in particular, Pangbourne Parish raised it with myself, that there are issues across the district.
Yeah, I think we clearly want, and he's not on the call, Sean Murphy to pick up and deal some of this, and Gordon would take that as an action and make sure that we've got some concerted and coordinated response, and obviously get, it's a piece of messaging, but regrettably criminal acts are criminal acts. Gail.
Thank you very much. Yes, Gail from the fire service. Just to confirm, we have been out to those. We've been to a number of areas recently in the hot weather, and we did go to Northcroft, and yes, it is a very busy area with quite a large number of kids swimming. So we've been in contact with Denise and the Water Safety Partnership and trying to just bring all that together. So just to agree with the sentiments of what everyone's been saying.
Thank you for that.
Thank you.
I see no further hands. So then really it's a question as whether there are any other actions apart from the two I've mentioned on that list that anyone wants to particularly pick up. No, nobody. Okay, fine, let's move on. So next item, a formal item, is declarations of interest. Clearly we have, Andrew Sharp isn't in the room, so we just have my standing declaration of interest. Are there any other interests anyone wants to make? No, thank you. And next item, public questions, and I'm going to roll petitions in. Have we had either public questions or petitions, Gordon?
No public questions or petitions, Chairman.
Thank you. Let's get on then. Members, the next item on the board is the HWB membership. Now, you will recall that we have discussed, and I think we spoke about this last time, that on the 1st of July, the ICS, the Integrated Care System, and more to the point, the ICB, the Integrated Care Board, came into formal being as a matter of law. And therefore, the clinical commissioning group disappeared and became effectively absorbed into it. And the legislation effectively replaces the clinical commissioning group with the Integrated Care Board across a whole swathe of bits of legislation. Importantly, from our point of view, the legislation that governs the operation of health and wellbeing boards. And you'll recall that one of the statutory members of a health and wellbeing board is what was the CCG and is now the ICB. And indeed, we have deliberately made our terms of reference that we have to have at least one representative of the council and at least one representative of the ICB physically in the meeting room for us to be quorum, which is why I'm so pleased to see Joe here. Now, we have been having discussions, I can say, we've been having discussions with the ICB up until about yesterday about this, but it has all been bottomed out now. And the position is that as from now until October, Belinda Seston is one of the two ICB reps, and if you go to one of your supplemental packs, I think it's the second one, you'll see that Dr. Heike Veltman, that was confirmed yesterday, in fact, is the other ICB rep, and Jo Reeves is substitute for both of them, hence me welcoming her. So that's the amendment to the list of membership. I simply ask you to note that and note that as from October, the link between this body and the ICB will be through the place-based partnership. So the incoming director of our place-based partnership, i.e. Berkshire West, will come onto the board, and we'll be looking at, may well be Dr. Veltman, but we'll be looking for someone from the sharp end, from the GP practices, from the PCNs, to be the other ICB rep, someone with that clinical aspect, which I think will be useful. And we'll also, Joe, obviously be looking for a second or third or fourth substitute, so that we don't have the position that we might find ourselves in Cora. And so we always welcome as many substitutes as you want to appoint. So members, please simply note that. So we now get on to the new, well, it's been on the cards for a while and we've been discussing for a while, but it is the Bob ICS. It is now in play, and I welcome Matthew Tate to speak to us about it. It's for discussion only. We're not going to need to vote on this, but over to you, Matthew.
Thank you, and thank you for inviting me along today, and apologies that it took us a little while to confirm the membership of the board, but I'm glad to see that's resolved now. So my name is Matthew Tate, and my role is Interim Chief Delivery Officer for the Integrated Care Board. And just in terms of a little bit about my portfolio, because I think there's lots of changes, so I think it's probably helpful just to outline that whenever I have the opportunity. So I cover in my role planning and performance, also the lead on urgent care and elective care across the ICB, and I also will be overseeing the place directors as they come into role in terms of delivery. So pleased to be here and just to start establishing, albeit virtual at the moment, relationships across the system. So I'm just going to give a very brief outline on the development of the integrated care system, and indeed the integrated care board, and touch a little bit on the strategy, prep work around the strategy for the integrated care partnership. And apologies, I will try not to use acronyms, but there are a number of very similar 3-letter acronyms used, so I'll try and talk work through them. So you've got the slide deck. I don't think we need to share it, but I hope I will just talk through it. So in terms of what we've been doing over the last 3 months, you would expect and understand, I'm sure, there's been a lot of focus on the technical establishment of the integrated care board and the transfer.
We're going to share the slide so everyone can see it. There you go.
Okay, so in my mind, I am on slide 4 at the moment. Great, thank you. So as you'd expect, a lot of focus on the safe transfer of functions. So making sure that we're clear, that we're aware of the statutory shifts across from the CCGs, and importantly, actually the safe transfer of staff across from the CCGs into the integrated care board, and make sure that we're clear on that and the technicalities around HR and payroll, as you can imagine. In terms of the technical setup, so we have now got to signed off constitution for the integrated care board, and as was outlined earlier, the ICB, integrated care board, was formally established on the 1st of July with the CCGs being dissolved. There is a working group that I think, Graham, hopefully you are involved in, around the creation of the ICB, and that's led by, the creation of the Integrated Care Partnership, and that's led by our chair, Javrika. That's working out the proposals for the development of the Integrated Care Partnership as we move forward. So just a reminder of the structures, which is on the next slide, please, if that's possible. So integrated care partnerships, joint committee between local authorities who manage social care, and the integrated care board as an organisation. The integrated care board is the NHS statutory organisation, and I'll come on to the membership, but that does include a local authority partner member. And then we have place-based partnerships, which Graham has already referred to. They include local authorities. They will be, from a governance perspective, there will be subcommittees of the integrated care boards around place-based partnerships. We're still working through how that aligns to the local architecture that's already in place across our system, and how we link those effectively into the health and wellbeing board structures and the three local authority structures that are particularly relevant for Berkshire West. So that's still working through, but I think broadly in terms of partnership working, there is a strong baseline to build from in the Berkshire West system and with the three local authorities. And then we've got the development of provider collaboratives, which are NHS providers and local authorities, potentially in the voluntary sector, coming together to deliver joined up services. So they're the key bits of the architecture, and all of which will or do involve local authorities, but as you've heard, some work to do in some areas of that. So next slide, please. Just a couple of slides reminding everybody of the goals of the Integrated Care Board. So these four are the national goals in terms of focused on inequalities and outcomes. Obviously, a need to focus around productivity and value for money and living within our means. But a focus on broader population health and healthcare, but also I think importantly, which is new to the system in terms of the Integrated Care Board, as opposed to some of the formal responsibilities of the clinical commissioning group, is this bit about the broader support from the NHS to around social and economic development. So again, a good platform for partnership development. Next slide, please. And then I think in terms of more of the roles that we're looking to create within the Integrated Care Board, obviously one is setting the overall system priorities from the Integrated Care Board's perspective, and we want and need to do that with partners in the public. We have a key role in allocating our finance funding and ensure that is in line with the strategy as we develop it. We have a key role in orchestrating system working between NHS partners and wider partners as well, in terms of bringing that together across the whole patient pathway. And I think an important element is we do need to earn our seat at the table. We need to be clear about where we come and add value, as opposed to allowing the providers of care to just get on and creating the environment for delivery. There's some of our goals. So moving on, if I could. So in terms of what we've done so far, so we did have an establishment board meeting on the 1st of July, as you'd expect, and that agreed a whole host of governance documents, but also it noted and received the inherited plans that we'd effectively created through the CCGs working together and working with system partners. So an operational and financial plan for the NHS. Also, we've been working with partners on a green plan that was received, and the system delivery plan. And hopefully you'll be a little bit familiar with that. That's really a sort of the development plan for the ICB from some of its strategic goals, and started with creating the Integrated Care Board, but now is moving into the development of place-based partnerships, provider collaboratives and strategy development. And some of the technical issues, obviously we've got the website up and running, and there's more information for people to see there in terms of the detail. And we've done a couple of stakeholder briefings over the last couple of weeks, which I'm hoping you've all seen, but if you haven't, please let me know at the end, and I'll chase up the circulation of that, trying to explain the respective roles of the ICB Executive Director team, and also announcing the place appointments at the end of last week. So we can move on to the next one. So just a quick run through of the Integrated Care Board membership. So you'll see that that's a combination of executives employed by the Integrated Care Board, the partner members across NHS Trust, primary care, local authorities, a non-executive representation. And as I said, we've also got an additional member for mental health as well, and a particular focus for one of our non-executive directors on digital. So they are the formal board members at this point in time. So next slide, please. We did take to our first board meeting a high-level commitment and plan around working with peoples and communities. Really important that we took that as a set of principles and embed that in our working from day one. And we've done some pre-engagement work around that, but adopted some important principles around working with partners and communities as we develop our plans going forward. Next slide. And we've mentioned place-based partnerships, and Graham mentioned those early on. So we are keen to delegate power and decision-making to our place-based partnerships as they develop, because that's where we think we can get most effective delivery and really push some of the fundamental elements of integration and wider work on wider health determinants. We've done some early thinking around that, but we do need to build on, as I said earlier, on the existing arrangements and make sure that does fit for local purposes. And as I've said before, I think that's particularly important in this system in terms of the three local authorities and the role of when we do come together and when we focus around the local authority geographies in terms of our working practices. Next slide, please. This is a bit busy, this one, I think, when I inherited this, but it gives you hopefully a bit of a feel for our plan. So this comes from our system delivery plan, which sort of focused on establishing the integrated care board, but is now moving on to look at provider collaboratives, to look at place-based partnerships, and start developing the strategy moving forward for the ICB and the integrated care partnership. So just a bit of a timeline there where the stuff we've completed is a lot of the technical stuff, and we're now moving on to some of the more developmental stuff. Next slide, please. And then a few slides on strategy. So Amanda Lyons is our Director of Strategy and is leading this piece of work for the Integrated Care Board. But obviously this is fundamental to the development of the Integrated Care Partnership, so needs to be done jointly and needs to very much build on the work you've done locally around health and wellbeing board strategies and engagement. So hopefully this gives you a bit of a steer on the work we've done today, which has been around engagement and pulling together some of the data from the fact packs as we move forward, and then an outline of where we go to in terms of our next steps. And we've got engagement groups and processes set up. So we'll start to work through that as we work to the end of the year for production of a strategic document. And then just a couple of slides highlighting a couple of areas that will be relevant for that and important. So next slide, please. So we mentioned inequalities a number of times. I hope you're familiar with this from an NHS perspective. This is we're describing it as core 20+5, which is about targeting areas of deprivation, but not merely focusing on that. We've got to look at the clinical pathways across that as well in terms of focus and improvement. Next slide. And this is just a high-level slide which gives you a readout of the present health index by local authorities. So I'm sure you'll be very familiar with this from your own local perspective, but you can see the range of measures and rankings from a national perspective that we will need to reflect and take into account. And the next slide, please. So I haven't seen the guidance yet. It is the week commencing the 18th of July. So I haven't seen it yet, but we are awaiting guidance. Possible I've missed it, but I certainly haven't got to it yet. And just a couple of areas that have been highlighted after the initial review of the 2022 Act, which are perhaps bringing some new areas into the health and wellbeing board strategies, although I think a lot of these are the enablers rather than the sort of service delivery areas. So bringing in a bit more focus around separating out integrated commissioning budgets, data sets, and health and care records. But I think broadly that's well aligned with the initial areas. I think it's just a slight categorization and next level of detail. Next slide. I think we're getting towards the end. That was the final one. Okay, so I hope I hope I haven't rushed through too quickly to that, and that gives you a feel for both the establishment issues around the Integrated Care Board, where we've got to, and a bit of a feel for next steps in terms of some of those developmental areas. That's great.
Oh, well, that was the fire alarm. We muted it for that. You didn't want to hear that. Thank you for that. Very interesting. I'm going to give a couple of comments, and then I'll see what other members want to ask or comment upon. While I do the first one, Gordon, can you take us back onto the slide deck? And I want to go, I think it was slide 12 or round about there. It was the one that was called System Delivery Plan Key Indicators or something like that. Yeah, on the, you referred to, and obviously quite rightly, the 20 number for deprivation, so the bottom 20% in the country, and reflected that so far as Berkshire West place-based partnerships concerned, Reading is the key indicator there. And I just want to reflect on that because I think that's absolutely right. I reflect that we, all local authorities, have areas of deprivation and need to deal with those. And obviously we want to deal with those, not that one. No, go back up. I think you're going up, up. Keep going, keep going. It's that one, it's the big chart. Yeah, 12. No, the chart, it was on page 12. Keep going, going up, keep going up. We'll get there in the end. That's the one, that's the boy. Right, sorry about that. Yeah, so I think, I seem to recall that so far as the bottom 2 deciles for local super output areas, which is what this is all based upon, correct me if I'm wrong, we in West Berkshire have 2 wards that fall into the bottom 2 deciles, and I think one is, I think they're both in 2. And I'm not certain how many Wokingham has. I know Wokingham's got 4 in the top 30, so Wokingham has some very undeprived areas, as I have to say that so do we. So therefore our difficulty in identifying those issues of deprivation is very much finding out where they are across a very wide area, because they can be individual pockets that we need to address and attack, rather than wider areas that other local authorities might find themselves. And I just wonder a comment on how we are going to work together to get right down to the nitty-gritty of the data and identify where those issues lie and do something about them within the not within the confines, but within the general broad strategy that we've adopted. So that's my first one. Hold that thought while I just look at the system delivery plan. Just want to comment that, as you say, there have been conversations going on about the ICP and the membership of the ICP. This is the body members where the local authorities have a particular part to play. There is a local authority representative on a member of the Integrated Care Board. That person is the interim chief executive of Oxfordshire, who has a background in health. So far as the Integrated Care Partnership is concerned, which is where the real conversations with the local authorities will go on, there have been many, many conversations, including the leader and I and myself, and we're still not quite there. I think we're getting closer to agreement as to what the membership will look like, but just bear with. But I certainly would say that the July 22 date for a formative ICP to have been established and the 3 PPPs to be established is slipped. I certainly hope that we've got everything in place for October when the place-based partnership director starts, and I'm very much working towards October as the date by which these various bits of the jigsaw will be in place. So Matt, I'll let you come back on that, and then we'll see what other members want to ask.
Yeah, absolutely right, Graham. I think you've articulated better than I did that where we are in terms of place-based partnership development and integrated care partnerships. So that's appreciated. I think in terms of the targeting work, I think that will take some joint work to do. I think from my perspective, and I'm not involved in all of the detail in terms of some of the work up on data prep, but I think there is a strong link we need to make in some of those areas around some of the work we can do with our primary care networks in terms of understanding that population and the at-risk population, and perhaps mapping those across to some of those areas identified in that deprivation work. So, and then we've got to try and be clear that we can target some real interventions in there. So not directly involved in the detail of that, Graham, but that would be my take. But I do see that there's a couple of hands up, and Tracy may well be able to give some more insight into how we might progress some of that work around targeting inequalities. So I'll leave it there. That's okay, Graham, from my perspective. But again, happy to take more comments and questions.
Indeed, and I'll take them in the order the hands have gone up. Councillor Vickers.
Thank you, Chair. Yes, I echo your concern about how we deal with pockets of deprivation. Obviously, the problem, which everybody will know, is that even though we might have fewer people in deprived areas than other parts of the country, it's actually a problem in itself, the fact that there are fewer, because people will themselves feel even more isolated and different and have lower self-esteem than in other parts of the country where there are larger areas of deprivation. So they basically are much more aware of the prosperity around them. So, you know, I think that is something that we all acknowledge, and I'm glad you raised that issue. I was looking at page 46 in relation to this, and I just wondered if I'd like a further comment on the fact that although we're in the top section for individual health, when it comes to healthy places, we're actually in the lower. And is that to do with standard of housing? Is that to do with air quality? I'd quite like a sort of further comment on that. And just a general concern that obviously I think we all feel that as we accept the new reorganisation, but we all feel that as things get bigger, you tend to lose your local connections. And possibly, I think there is a concern that although we're breaking up into little sort of places and local partnerships, that we'll all be battling as regards priorities, and hopefully West Berkshire will have a strong voice, and that its concerns and priorities will not be overridden by others in different parts of the area.
Well, before I come to Tracy, I'll comment that if West Berkshire doesn't have a strong voice, you can blame me, because I'll be in there pitching, I can assure you. But I do think that we are having some very good. We've had conversations already, obviously, between the leaders of the 5 local authorities, the 5 first tier local authorities sitting within Bob have had conversations, and other members, including me as portfolio holder, have been in the room for those conversations to some extent. The chairs of the 5 health and wellbeing boards have met virtually and had a conversation. So conversations are, we're getting to grips with this, and certainly I think there are clear opportunities here to get aligned strategy, and no doubt Tracy will talk to that, to get it, and maybe Zakia wants to as well, to get aligned strategies so that where there is commonality, and that is something that is obviously better delivered at system, it gets delivered at system, but where it needs to be delivered at place, it gets delivered at place. Where it needs to be delivered at locality, it gets delivered at locality. And so far as place is concerned, I do think there is, again, we're waiting to see how those committees of the ICB, the place-based partnerships, form, because there will be, for our point of view, Berkshire West, there will be a major conversation within the place-based partnership as to how this stuff is delivered. So I think it's interesting. I will say it's interesting times. I won't put it any more highly than that. Let Tracy come in.
Thank you so much, Chair. Tracy Daskevich, Director of Public Health. Good morning, everybody. It's just to pick up on the data point mainly, but I think your point, Councillor, just now was very well made. With the data, there is a piece of work that's taking place with Amanda Lyons within the ICS structure, working with the 3 directors of public health, so myself, Jane from Buckinghamshire and Anne Saff from Oxfordshire, to look at how we build a data profile around our wider system, but absolutely going down to place level. And we're doing this threefold. So we're using the Joint Strategic Needs Assessment, we're using population health management programmes, and we're also using connected care to look at how the data works, not only to understand our local profiles, but also to understand how people access services, and more importantly, the barriers to people accessing services. So that is a big piece of work that's going on in the background to try and understand, in particular, the quintiles as we see them, but looking at them both from a health inequality point of view, but from a health equity perspective as well. So hopefully this work will continue to grow and be fed in at ICB and ICP level. From my perspective personally, there is a huge emphasis which is welcomed within the ICS structures around health inequalities, and the core 20+5 gives us a really good mandate around this work. But actually at the table, public health still sits on the periphery of that. And I would like public health to have a stronger voice as we go forward, because for me, the data is important, and I think we are data rich. But we need to move that data into intelligence and insights, so we really understand what matters to our populations. So there is work going on, and it's how we can move this at pace to make sure that it also aligns closely, as you said, Councillor Bridgeman, with other strategies to make sure we're meeting those priorities already identified across our strategic systems.
Yeah, and I think I'd come back and say that clearly data is very important, because after all, if we have a strategy and we don't want to know whether it's working or not, we need data. We need to understand what's going on out there. So thank you. Andrew.
Thanks, Chair, and apologies again for being slightly late. I've got a number of points. I do apologise, but I've sort of been involved with what was the strategic, the STP, can't even remember what it was called those days, all the way through this. So, I feel really embedded with the whole thing. I've got to agree with the Chair, Councillor Bridgeman, about our concerns about deprivation, because we expressed this before the whole thing started, that with one pot of money across 3 big areas, there was a fear that there would be an aggregation of where service would go. So basically, because Oxford and Reading have worse areas of deprivation in sheer numbers, the attention would naturally tend to ebb that way. Sadly, on the core 20+5, we put in a joint bid with the ICS, which we changed, because it was originally sort of, let's put all the money into Oxford and Reading, and the 5 health watches actually agreed, well, let's put the bulk into Reading and Oxford, and then do slightly less work in West Berks, Wokingham, and Buckingham. And that was rejected, and the whole project's gone into Oxford and Oxford and Reading, which I thought was a really disappointing start. On the positives, though, delighted there's 4 non-execs, and if there's any information on where they come from in terms of representation, that would be great. I have huge concerns about, and Tracy touched on this, public health missing and being peripheral on some really key activities and boards in the ICS. I was at Quality yesterday, which is really important, and we had no one from the local authority, no one from public health, and it started to feel, we were talking about inequality prevention and everything else, the NHS was again taking the lead, solving everything. And in terms of pressures on the system, detox, everything was mentioned, but there was no voice from anywhere else in terms of saying, well, we had a workforce debate. Dom care and carers was touched on, but not to the same level of issues of GPs, paramedics, etc. And I don't think, again, housing strategy was even mentioned, and should be, because it's key to this as well. And that's where that local authority and public health element comes in. Prevention, I still think we have to wean ourselves off this culture of we will solve the illness when it arrives at hospital. it's a default position of the NHS that give us a sick person and we're happy. You know, we've almost got to make public health and prevention the first thing that happens, and the inequalities work is obviously to be welcomed. And then finally, cross-border issues, which is a double hit for West Berks in terms of we don't have as many in deprived areas. We've also got a huge swathe of our population using non-BOB ICS trusts like Great Western, like Hampshire. Big debate on maternity yesterday, and I had to pitch in and say, well, look, we're trying to get Great Western and Hampshire into Berkshire West, but they need help from the ICS. We currently don't have connected care with records and things like this. Sadly, that isn't in any of the NHS guidance in terms of goals about, you know, how do we follow the patient flow, not the map. And I think that should be changed as soon as possible, because why should someone from Hungerford experience poorer care than someone from Reading or someone from Oxford just purely because of geography, where records can't be transferred across? But thank you very much for a really detailed thing, and the acronyms frightening. Let's have acronym busters in every single public meeting, please. I say this every time, it doesn't happen. Let's get them in there, and public health needs to be in everything if they're resourced. Thanks.
Thanks for that. Before I come to other comments and questions, just one comment. While you were talking, I went to the BOB website, and there are biogs of each of the non-execs, so they're there for you to read at your leisure. Matthew, is there anything you want to respond to before we move on?
Well, I put in the chat. Happy to. We will be circulating further stakeholder information anyway, so I expect something will come out specifically on the non-execs as well as the website detail. And happy to take away the challenge of engagement, particularly around public health. Happy to link with Tracy, although I know she's linking in with Amanda in terms of our emerging governance structures, because there are a number of groups that we have flexibility on engagement and involvement. So I'm confident we can look to rectify gaps as we develop our groups and structures going forward.
Thanks for that. Rick, Councillor Jones.
Thank you, Chair. Just a couple of points, if I may. I realise that it's still early days and there's still a lot of talking going on, even though I think we've been talking structure and governance for about 3 years now. And what I wanted to just ask is there any, while we're doing all this, is there any evidence that we're actually improving the experience of our population? Because I'm not aware of that information being put out generally. I think the local authorities have contributed to the integration agenda by producing now a joint strategy between the three local authorities, which is certainly progress. Will, in all this change, the health and wellbeing boards have a real role, a real value-added role, and some teeth to actually get things done?
Okay, so that may warrant wider comments, but I'm happy to respond and start the debate if that's helpful. I think on the delivery focus, so I think that, you know, of course there's a degree of distraction when we're talking about organisational form changes and a degree of additional focus to make that happen. In terms of improvement, I think there's a lot of focus on how obviously there was a lot of focus on during the pandemic in terms of maintaining services and the quality of those services, and there's now a lot of focus on coming out of the pandemic in terms of recovery of services and addressing some of the challenges that we're facing. So there are areas of improvement, but I think we're all aware of the level of challenges across both health and social care in terms of that recovery trajectory. So we are seeing a recovery of our elective care, and we're seeing improvement in the backlog in terms of service delivery. Urgent care is very pressured. I think you'll be aware of that from the general information out there in the public, but we are working hard to maintain quality of services and looking to put in additional resource and services as we head into the autumn and winter period. So there are some areas where we can demonstrate improvement and recovery coming out of the pandemic, but there are as well, as you'd expect, areas of particular challenge where we are still really grappling with the demand around the urgent care pathways and some of our the demand going into our A&E departments. On the role of health and wellbeing boards, I think that's fundamental to getting the place-based partnerships working in the ICP relationship right. But I think from my perspective, there is more work to do in that space, and others on the committee may wish to comment. But I think that is an important part of the work going forward to establish that relationship, so that we've got the right leadership across all bits of the governance and the architecture.
Okay, thanks. I think I would reflect on the role of the Health and Wellbeing Board. A couple of things. Firstly, obviously, we have all health and wellbeing boards have statutory function. There are things that they have to do, reports they have to receive, and they're obliged to be consulted on certain things. So I think there is that role there. But I do think actually that going forward, there is going to be more synergy. I very much trust there will be more synergy. Certainly, I've had far more conversations with other chairs of health and wellbeing boards than I ever did before, and I suspect than Rick did or Howard did preceding me. And because there is going to be, I think, some synergy between health and wellbeing boards and synergy and the representatives of local authorities on the ICP, there will be health and wellbeing effective representation at system level. Then we've got health and wellbeing representation at place level. And so, you know, as I say, I think one of the very important things from our point of view will be the way the PBP for Berkshire West comes forward, exactly what that looks like and who's sitting on that committee and where the links are between that and the health and wellbeing boards. But certainly we're having conversations between ourselves. And of course, Berkshire West has a joint strategy, which we need to see delivered. So to some extent, it's suck it and see, and we'll see how this thing goes forward. But I have some hope that things will be very good for and fundamentally for the benefit of our residents, for the benefit of the population health at a local district level. So unless someone else has anything burning they want to ask Matt, I will move on. And now it's the Tracy Daskovitz show, I think, because we have the annual Director of Public Health report. Again, an item for discussion only. We're not going to take a vote. So Tracy, over to you.
Thank you very much, Councillor Bridgeman. Within your packs is the full annual report. In the interest of sustainability and our issues around climate change, we will not be moving to publish this as a paper document, as has been the case in previous years. This will remain an online document. So present to you today one of those statutory documents that has just been mentioned in terms of a report that has to come to the Health and Wellbeing Board on an annual basis, and that's the Director of Public Health Annual Report. These have been in place in this format since 1988 now, and it is the Directors of Public Health responsibility and a vehicle in which we can present the state of the health of our population. We can either do that in a general way or by theme. This year, the theme has been chosen around sustainability and climate change, with a particular focus on food production and the impact that has on our climate. So the report is there to see. It is here for information and onward sharing with networks. There's a lot of information in there, and because we've had the benefit of producing it as an online document, we've been able to take full advantage of putting in some video case studies throughout the report, which have been taken from various community groups across Berkshire. It is a joint Pan-Berkshire annual report this year. So we've got community groups in video form showing the projects that are going on right across our patch around food sustainability and food production, both in terms of where we can go and get our sustainable food from, and where we can reduce packaging, but also understanding about how farm reared food creates an impact on our environment. So a huge amount of information there for your interest and at your leisure in your own time. I'm happy to take any questions, but overall this is just to share the Directorate Annual Report with board and then onward sharing with our networks.
I guess a couple of questions from me. One is how this is spread out into our populations. They're aware of it. I mean, what comms have we got around this, and to what extent, so far as this council is concerned, are we involved in making sure that the message is that out there that this report exists and is online, and please have a read of it and see what's interesting in there, because there's an awful lot in there, awful lot of data in there as well. So it takes some reading, but it's a very interesting document. And the other question is, and this may not be something you can answer because it tends to be more for Stuart and the other half of Berkshire, but I'm just interested in the extent to which the financial difficulties of Slough might have impacted anything that's going on the ground so far as public health is concerned.
Yeah, so to take the first question, we have done a soft launch. We will do some more targeted comms around this once it's been to the Health Wellbeing boards. So hopefully by September we'll do a harder launch on this, but obviously we do want Health Wellbeing board colleagues to see it first. So it is available on the Berkshire Public Health website and has started to be shared with networks. But like I say, the Health Wellbeing board is the start line really. So as this will be the start of a more fuller conversation around that. Interesting points around Slough, and I think it's one that applies for all of our communities that have different levels of deprivation and different challenges around access to high quality food. And some of the videos within that covers this. So whilst I think Slough has particular issues, there are other areas across the patch that consideration we've had to consider, and some of the community groups really address that in a very coordinated and co-productive way, and helps us really get a sense of the difficulties that people have in accessing good quality food, healthy food, particularly those people living on a budget. So listening to those community groups has really helped us, and it will help us as we move forward in terms of thinking about food sustainability and supporting our families into the future.
Sorry, perhaps my question wasn't as accurate as I wanted it to be. My question about Slough isn't so much about the population of Slough, much as I fully appreciate the different issues that arise in Slough and possibly in Reading than the rest of Berkshire. It is more to do with the bankruptcy of Slough Council and the fact that commissioners are in. And my question is the extent to which that might or might not be having an effect on public health, the public health service in Slough. As I say, you may not be in the position to answer. It may be a question for the Director of Public Health for Berkshire East, but I just thought whether you had any thoughts on that at all.
Yeah, certainly. So from my perspective, and obviously Stuart would be able to give you a fuller answer than this, on areas where we're working pan Berkshire, we are still coming together as a whole public health offer, and that includes our colleagues from Slough. Equally, the work that I'm doing around the Ukraine homes, again, Slough is very much represented in that group. So those things that we are working at scale on from a public health perspective, Slough is still fully engaged, but in terms of the internal working mechanisms, Stuart would be able to give you a more accurate perspective.
So we'll now take hands that are up. So Councillor Vickers.
Thank you, Chair. Yes, thank you for the report. I welcome it, and I'm glad the focus is on food. I think this is very pertinent and very timely. This is a global problem, I think we all know. And I think we're all aware that it's the poorer countries, the ones that are exporting food to us, that are suffering most. So it's a vast problem, and it really needs to have countries getting down to tackle it, that the poor are always going to be the ones that suffer here. We've got enough food in the whole of the world to feed everybody, but we still have millions and millions of people in poverty, in food poverty. So why is this the case? And if governments can sort this if they have a mind to, but we need to be conscious of the role that big business plays here, that small farmers are often overridden by their governments. Bringing it down to local issues, again, in this country, it's the poor. Poor are in food poverty. The report is comprehensive. I haven't read every word, but I have looked through it, and it's obviously it's bringing together a lot of the issues related to food poverty. But I was disappointed in its conclusions to some extent, that once again, it came down to the individual and what the individual can do. And I think we all recognise that, okay, we all need to live healthy lives, etc., but the ability to do that comes down to one thing: to have enough money so that you can buy the food you want, so that your focus of your day-to-day living isn't on where is the next penny coming from. And more now we're seeing that people are desperate. They just don't have enough money to feed themselves and their families. So how can we preach to them about what they should do as individuals when they don't have enough money? So need to get down to the nitty-gritty, that the benefit system needs to be sorted. It's not just jobs, it's the way we handle and treat the poor, and we need to make sure that every family, every individual has enough money to buy the food that they need, and then we can start preaching to them about the healthy lives they should lead.
I was going to say if you wanted to say anything, Tracy, but no.
Thank you. A point brilliantly made, Councillor Vickers. I think it's absolutely right. I think your points around the global food production and dissemination is absolutely key. But equally, your points around food poverty and people's access to food, and how we can support families, and that cannot be just about having more food banks available to people. That isn't the solution. We're going into probably a period of extreme financial crisis, one that we probably haven't seen for a generation. And what comes with that is, as we enter winter, we are going to see families making a decision between heating and eating. And we know that that is going to be a very real choice for most families. We also know that about 20% of the children in this country only get one meal a day. So in terms of child poverty and food poverty, and that has the knock-on effect in terms of a child's ability to learn, child's ability to play and interact, and give them the very best start in life. So all of these are very clear challenges, and I think food is a focus of that. But I agree with you, there's a wider system change and how we can support families in the most meaningful way, that isn't about judgment and stigma, but making sure that they have a service that's available to them, that's going to help them move on and support their families through what is going to be a very tough period of time.
Thank you very much. Thank you for your answer.
Thank you.
Thank you. And thank you, Tracy, for and your co-author, who I'd like you to thank as well, for a report that is really easy to read. And as someone, like many of the people in this room on this call, who has to read many reports on a weekly basis, this was actually one that I enjoyed reading. And I will probably go back and read again, because I think possibly in the same way as Councillor Vickers has said, it was quite difficult to read every single word, and I wasn't able to go into all of the interactive pieces, which I do want to do, because there will be aspects and community groups and information that I won't have been aware of across Berkshire, which I think will be really useful. I like the idea that what we're trying to do, or what it sounds like you're trying to do here, is to give some practical advice to those who can take that practical advice. And I totally also agree with what Councillor Vickers has said with regards to those who are in the most deprived situations and will struggle with some of this practical advice. And we do need to do something about that. But for those who can, some of the simple things you quite often see in the press, in particular around use by dates, I think is really interesting. And there have been some programs by some very pro-Leith, for example, around how you can reduce your food waste. And these are very practical, and you could say common sense, but actually sometimes you get caught up in life, and it can be so easy to just take an easy meal off the shelf when you're in the supermarket and things like that. but I totally agree with if you can spend some time planning what you're going to do in terms of meals and where you're going to source that food from, choosing not to always eat meat, which is something that I and my family are now doing. And I've been brought up as a child where it was always meat and 2 veg. That was your meal. So there is a culture change as well here. But I think I will certainly be recommending that my residents read this report. I can't say I've ever said that about a public health report, but because I think there are some really useful practical tips. And in particular, I really like the fact that you've included some examples here where people power can make a difference. And I think we need to be taking these sorts of steps ourselves. And I absolutely will be making soup this weekend with the vegetables that I know are not quite as nice as they were that are in my fridge at the moment.
Good use of our wonky veg is always good. Thanks, Councillor Stewart.
Councillor Dockley.
Thanks for the report, Tracy. I'm not going to repeat what Councillor Stewart just said, because actually I agree with most of it. It was a really informative, useful report. And actually one of the things, just before I come on to my actual question, is how we actually pull those tips out and make them even more bite-sized and communicative so that people don't have to read the whole report, so that we get some of that information flowing directly out. So I thought the report was really useful. I enjoyed reading it, and I'm not going to repeat everything that Councillor Stewart said. I just have a question, and I suppose I was reading the front cover and thinking, how do you decide each year what your theme is? And I can't remember what last year's theme was. So therefore I'm thinking, and what do we then do about your themes? Because I can't, I'm sorry, remember what last year's theme was. Is this tied to our joint strategic needs, where we're actually all working on the same thing and we can build it in? How do you, I mean, it's a really good theme, don't get me wrong, I think it's really, but how do you decide which theme? And then once this report's published, how do we actually ensure that it's input into our systems? Because I honestly can't remember what last year's theme was. And when I sort of look at the big picture items that we've been dealing with over the last 12 months, I don't actually think this particular item has been a main theme for us. So I'm just kind of trying to work out in my own head how this all sits within our system and what we're actually trying to achieve and what we now do with what is a really good report. And that's, you know, a really useful theme. I think that's where I'm sat.
And I think that is a brilliant question. The answer is it actually isn't very systemic at all. And it's a question I intended to ask it at the end, but it's timely to ask it now, in terms of whether it is something that the Health and Wellbeing Board would like to be part of in terms of choosing the theme. Primarily, the way they're chosen, it is genuinely, it's either a topic that has been very high profile or a topic that hasn't necessarily had the airtime it could have. So it can be all sorts of things. I mean, the topic that I would really like to address next time, which was the question I was going to ask, was very much about recovery from COVID, but through the eyes of children. I was going to do it as a comic strip with pictures, going into the schools and asking primary school children to talk about what they think public health is about, and produce that in more of a comic strip, still online. But I would like to work with our primary schools to produce next year's annual report, so that we can have that coming through around our priorities, around the health and wellbeing strategy, and to get the views of our children around that. So genuinely, it is something that is seen as purely by the Director of Public Health, that they feel is the topic that would be of interest to colleagues and the community, which isn't necessarily the best way of doing it in terms of making sure that it's representing the loudest conversations that we're having within our various networks. So I'm very happy to make it more of a collaborative decision-making process.
Thanks, Tracy. That's really useful, because I must admit, when I opened it, I was kind of expecting COVID, considering where we've just been, not taking anything away. So I think having that joint around what are our loudest conversations, priorities.
Welcome that. Thank you. Sorry, my dog's decided to sing at this precise moment.
Yeah, we worked out.
Councillor Masters.
Thank you, Chairman. Thank you, Tracy. Just to echo everybody else, a really interesting and pretty comprehensive report, not just on the overall global issues around food, but also the local initiatives across East and West and across Berkshire as a whole. So that's really, really good. I just got a couple of questions. It's clearly a global challenge, and you touched on it just in your answers to Councillor Doherty about the conversations within your wider network in public health and and health and well-being. There's quite a lot of references to reducing meat consumption, vegan and vegetarian plant-based diets. Do you see on the horizon through your networks a greater push to see more policy regarding that at a local level, so we can bring more sustainability and less dependence on import of cheap meat products and cheap fruit and veg, for example, from across the world? Because the whole, as it's clear from your report, food is a public health issue, and very much affects disproportionately the more disadvantaged members of our community. And often going plant-based, for example, and making those ethical choices is more difficult for the people in the lower economic band in our communities. So if we can have a more sustainable, locally sourced farming policy, etc., do you see that coming? Is that the conversations you're having nationally?
Yeah, so there is a lot happening globally in this conversation, and I think when we think about the environmental summits that take place, food and food production and food transportation are really hot topics in this space. A lot of it is consumer driven. I mean, I certainly, just in my lifetime, if I go back to my childhood years, there is no way I'd have been having strawberries in October. I'd have had strawberries for 3 weeks during the summer months, usually around Wimbledon time, and that would have been it. Whereas now we can get, soft fruits and berries all year round because of the import, and that is consumer driven. So there is something about the cheapest way to eat is to get your food as close to your front door as possible. The stuff that has the fewest ingredients as possible is always the cheapest, and we also know that food is the food that isn't processed. So even a bag of oven chips, for example, that you think will just have potatoes in, have gone through a processing and coating process that makes that potato less healthy than one that's straight out the ground. But these are all ideals, and not everybody can afford ideals, and not everybody's got time for ideals. So there is always going to be a consumer push around this. The eating of farmed animals is one that is top of that, because of the use of agricultural land to house farmed animals, but also the methane and the impact on our environment from farmed animals. So there's double jeopardy around farmed meat, just purely because of the volume and quantity, and also the fact that all of our homegrown meat doesn't stay in our home country just to feed this country. Again, the export and import rules apply. So it's a hugely complex area, and there is something about gently educating the consumers around it, that it isn't usual and isn't necessarily essential that we have strawberries in October. We've got very used to, over a longer period of time, seeing more common fruits such as bananas, for example, that are primarily imported. We're used to seeing those, but others have become new. It's only been the past sort of 10-15 years that they are year round. So there is that. So buying in season, which means that you're only going to get British lamb for a couple of months of the year. But buying in season and eating in season can make a huge difference, not only for your health, but also for your pocket. So it's not all about veganism and plant-based food. You know, people need meat-based protein. So it's not a lecture about going into a plant-based place, but eating as close to your front door, consuming local produced meat that is generally not farmed in such the same volumes and doesn't have the same production environmental impacts, can make a massive difference.
Thank you, Tracy. Just a broader point to, you know, maybe through the chair. And Councillor Doherty asked about the previous reports and how it ties in. I think maybe, you know, I don't know what the procedure is when, you know, obviously we go to consultation for our main targets on the health and wellbeing strategy, maybe tying in with this and previous public health, you know, reports is a way to go to make sure that's all joined up, so there isn't the duplication, for example. Yeah, I mean, I think I like joining things up, as Tracy knows, trying to make sure that we're all singing from a similar hymn sheet and that we're not duplicating effort in particular. So yeah, let's take that one on board. Tracy, you've noted that, and we'll no doubt talk on. So thank you, members. Thank you, Tracy. The next item is the West Berkshire Pharmaceutical Needs Assessment. Now, members of council hopefully will recall that I circulated the draft that was out for consultation back about, well, something over a month ago. I made a comment to those who've produced this, and we'll come to that in a moment, that there was a references to West Berkshire as a borough. I made the point that we were a district. There's still, by the way, there's still a couple still in there need to be sorted. You haven't quite got all of them yet. Please work through the word borough and see where it pops up for West Berkshire. I'll give you 4.6 just as one example. But now I'm going to turn over to Healthy Dialogues. So we have Dr. Joel Malimba and Pooja Patel to speak to us. Don't know how you're going to play it, but I leave it to you to tell us what you want to tell us. And this, again, members, is an item for discussion only. But obviously, you were asked if you wanted to engage with the consultation. Over to you.
Thank you very much. Gordon, I don't know if you're able to share the presentation on your screen.
Bear with us. Here we go.
Okay, thank you very much. So thank you for having me. My name is Joel Malimba. I'm with Healthy Dialogues, and we were tasked with the production of the P&A. If you just move to the next slide, please. Thank you. So the P&A is a statutory document that needs to be produced by each Health and Wellbeing Board every 3 years. If we'd been in the normal cadence, there would have been one due last year in October, but because of COVID, it was deferred by a year. But the expectation is that one will be published by the 1st of October this year. So there's two main things that the P&A tries to capture. First, it informs of commissioning plans around pharmaceutical services. And the other big thing is the NHSC uses it to support decisions on any applications they get for pharmacies, whether it's opening of new pharmacies or the change of premises. So they use this document to see if there's any justification for any application that comes through to them. So I'm just going to talk through what the process is of production of the P&A, and then give you a quick update of where we are at the moment. So if we just move to the next slide, please. Cool, thank you very much. So the first thing we do is we gather data from a number of different sources. So we will look at the services that are being commissioned. We'll get that information locally from the council, as well as the national services from NHSC. We will gather views from the general public, and my colleague Pooja will talk us through that in just a bit, as well as from the pharmacies themselves, the pharmaceutical contractors. And we look at various national as well as local data sets. We'll look at things like the demographics, the population makeup, any expected changes in the size of the population. We'll also look at information from OHID, what had previously been Public Health England, on some of the health issues that are prevalent in the area. In addition to that, we take into account the national strategies and policies. So we'll look at things like the JSNE, and we'll incorporate that into the context of the production of the P&A as a whole. So the entire process is overseen by a steering group. The steering group consists of the members that you see there. So we'll have the public health team, and we'll also have the LPC. And we, during the production of the P&A, it was an ICS, but has now morphed into Bob. And we'll also get some input from NHSE, as well as the various local medical committees and Health Watch, representing a voluntary organization. And we also had a patient representative from the general public. If you just move to the next slide, I'll let Pooja take over from here.
Thank you. Thanks, Joel. So I'll just talk to you a little bit around the public engagement and sort of our engagement strategy. So we disseminated a public engagement survey to capture the views and experiences for residents around the frequency and reasons for pharmacy use, accessibility and sort of the distance traveled to pharmacies, reasons for their chosen pharmacy, and we did a section on protected characteristics for the equality and impact assessment. There was also a contractor survey that was disseminated to capture commission services that pharmacies already deliver and services that they would like to deliver. So if you go to the next slide, I'll just talk to you a little bit about more in detail around the public engagement survey. So we took a whole population approach and a targeted approach. In terms of the whole population approach, we worked alongside the Berkshire Local Authority Communications team, and the survey was shared via various platforms, social media platforms, and it was shared on the resident e-newsletter. It was also published on the Public Health Berkshire webpage, and that link was the one that then was embedded when we were contacting other leads. So it would take people directly to that homepage. And then at a more local level, we worked with the communications team at West Berkshire. And again, the survey was shared on the council website and e-newsletters, social media pages such as Facebook, Twitter, next door. We also shared the survey with Health Watch and the West Berkshire Volunteer Centre too, and that was disseminated through their e-bulletins. We then took a little bit more of a targeted approach to reach people sharing protected characteristics, and we sort of looked to the steering group to support us with this as well, to provide us with relevant contact details, as well as a team just researching local organisations too. So the survey was then published on the community panels, such as the Adult Care Community Panel, the Health and Wellbeing and Caring for Children and Families Community Panel. We shared it with some colleges, such as Newbury College, and also requested for it to be shared through the Community United platform too. So we had quite a comprehensive engagement plan that was shared with our steering group as well. Whenever we offered to share the survey, it was sometimes through a link. We offered paper copies for anyone, for those digitally excluded, and also offered to host any focus group sessions as well with any community groups. Overall, people were generally happy with the services. Residents were generally happy with the services that they received, and most chose their pharmacy based on location. most respondents, it took them about 20 minutes or less to reach their pharmacy by car or walking. And about 2% of respondents reported that it took them between 20 to 60 minutes. In terms of frequency, it was people would visit their pharmacy at least once a month. And then in terms of the contractor engagement survey, we had 19 out of 21 responses, which is really well received, considering the survey was disseminated sort of through the pandemic as well. I'll hand that back over to Joel.
So on the 10th of June, we put out the first draft of the P&A for public consultation. That's a statutory requirement. So it's going to be open until the 9th of August. And when we say it's out for public consultation, it is published on the council website, which is there. But in addition to that, there are some specific groups that we have to get in touch with. So we've emailed the groups that you see listed here to show them the draft so they can make any comments. I'd like to specifically point out that we reach out to the health and wellbeing boards of the neighboring districts, neighboring local authorities, so that they can comment on the P&A. So once the P&A once the consultation period is complete, if we just move to the next slide, please. Once the consultation is complete, we will take the feedback that we've received and feed it into the next draft of the P&A, and we will then have this a draft of this finalized P&A, which we will share to the steering group. And once they're happy with it, we will then share it with the health and wellbeing boards as a whole, ready for publication by the 1st of October. And as far as the asks at the moment, we just want to let you know about to update you on the process and to invite you to engage with the consultation period and to make any comments you may have on the draft. And regarding what you said, Councilman Bridgeman, I apologize that we did catch all those references to Borough, but we will definitely look at this and have it corrected by the time the next draft comes out.
Thank you. Members, hopefully if anyone's got to Joe, I'll come to you in a moment. We'll try and rush through questions because we're just a little bit over time at the moment, but I've just got one point to make rather than a question. And the point is this: clearly, if a final draft is coming to the Health and Wellbeing Board on the 29th September and the P&A has to be published for the 1st of October, it's pretty much a fait accompli at Health and Wellbeing Board on the 29th September. So I really do encourage everyone to engage with the document now, rather than on the 29th September spotting all the things they should have raised before, should there be any. So I encourage everyone, as I did back in June, to engage with this process. Joe.
Thanks, Chairman, and thanks, Joelle and Pooja, for the presentation. I've got a couple of things, but I will be quick as possible. I was thinking back to the ICB update that Matthew Tate provided, and looking at the health index, which generated some discussion, particularly the healthy places aspect affecting West Berkshire. So the 5 lowest scores in that included distance to pharmacy as one of the key items that we were lowest ranking in, but noting in the draft P&A, it concludes we've got good access to services and no service improvements recommended. So just wondering how we reconcile that, because certainly in West Berkshire we have quite a large number of dispensing practices. We've got community pharmacy. So just thinking about when we're looking at the health of our population, how do we reconcile the two things that are giving us slightly different impressions when it comes to access to pharmacy in West Berkshire?
Okay, so as far as the distance of travel, the 20 minutes is based on a national survey. 95% of people in the country can reach a pharmacy within 20 minutes, but they need to apply that in a local setting to see if there's any changes that need to be applied. So we met with the steering group and discussed this, and we agreed on the 20-minute travel time as being appropriate. But in addition to that, some of the provision is not done just by pharmacy. Some of the provision is done by the dispensing GPs, and there is decent dispensing GP coverage in West Berkshire.
Thank you. And my last question or point was about community pharmacy workforce. Locally in the ICB, we've got good relationships with the local pharmaceutical committee, who highlight frequently the impact of workforce challenges in community pharmacy, like workforce is an issue across many aspects of the system. So just wondered if you could comment about those concerns, given that anecdotally, certainly we are aware of those pressures, but yet there's still recognition in the report of good service and no improvements suggested. Thank you.
So we haven't. So in some of the other local authorities that we've worked in, we have gotten some comments, especially from the public, that there have been struggles in terms of they'd go to a pharmacy and there wouldn't be anybody able to provide them with any service. We haven't had that from West Berkshire, but if there is concerns like that, then we'd certainly be able to look into it and bring it up with the LPC to see if there's any specific remedies that can be put in place to address something like that. We know during COVID, most pharmacists were really struggling to have enough staffing to meet the requirements, the pharmaceutical requirements, but we haven't had about that in West Berkshire.
Thanks. Councillor Stewart, sorry, Councillor Vickers, isn't it? Yes.
Thank you. I mean, I'll be brief. Joe's actually raised two issues I was going to raise, the discrepancy in the survey and the pressures on staff. But I'd like to sort of, congratulate you on an excellent response in your survey and all the wide, the breadth of consultation that you appear to have had. Another issue was just about, I think you mentioned somewhere about how people use their pharmacies. I'm not sure that I saw much data on that. I suppose that's a little bit more to sort of to sort of get a feeling of. But we know that people are being encouraged to consult their pharmacists rather than to take issues to them that don't need to be taken to their doctor's surgeries. And I wondered if you've got much data on how people are using their pharmacies in that respect, and whether the pharmacies have facilities for this. Do they all have small consultation rooms? Are there always the staff there that can take this on board? Those sorts of issues. People who are there to consult, do they channel them to a different queue? So is that something you have data on?
So with the public survey, there was a series of questions where we used to try and capture how people use the pharmacies, and we're looking at things like time of day, the reason they go to a pharmacy, why they choose a particular pharmacy they utilize. So those were the kinds of questions that we covered, and they're listed in detail in chapter 5 of the P&A. The question you asked there about the private room, that was something that used to be done in previous P&As, but the feeling had been that the question, we can capture a lot of that information from NHSE if needed. So we don't cover those questions at present in the contractor survey, because there's also the recognition that with the pressures from the challenges of COVID, we should not overburden the contractors by asking them too many questions.
Andrew.
Thanks, thanks Pooja and Joel for the presentation. We were involved initially quite heavily with the PSNA work, which was pretty good. I think a couple of comments. One, we've got to make sure we get a reasonable number on something that's so important, and the challenge we've got, it's a really complicated topic for the public to wrap their head around, and even the title of it, you know, it's kind of, you know, it's really super professional, and I wonder whether some work can be done in terms of ensuring, you know, we get a decent response in this, because people do rely on the services locally for all sorts of things. And actually, with the whole way the NHS is going forward, pharmacists are going to become more and more important and crucial, whether it's through vaccinations, whether it's through alternative GP appointments. You know, practically every time a service is announced, you find out the community pharmacist is doing it. The other two items that I forgot to raise at the time, one is, where's the impact in the results of when it's published of increased housing provision re-pharmacy? Is that taken account of? You know, if we know we're going to have another, I don't know, 5,000 homes, where's the pharmacy going to come from? And I suppose really key, and this involves practically every conversation we have now, is where are we in terms of workforce levels, vacancy rates and things like that? And will that form part of any conclusion or anything, or comment? Thanks.
Thanks. You raise a good point about how technical the document is. We have to kind of walk a tightrope here, because if we make the document non-technical, then it will not meet the requirements that NHSE have. And there'll definitely be a wrapping of the knuckles from them, because there's specific statements that have to be very carefully worded that needs to be done in order for NHSE to agree that the document has met its requirements. So, in as much as it would definitely get more of the public behind it to have the document be less technical, it will not meet the requirements that the NHSE has for what they use the document for. In terms of the impact of increased housing, we do look at that, and in particular, we look at the change that is expected during the lifetime of the PNA, which is 3 years. So there isn't that big a change that's going to happen, but we do mention it in chapter 7 and in more detail in the conclusions. We say which factors we put into account in terms of the future provision of the pharmacies. Going back to your point about workforce, we haven't had any indication at present that from the contractor survey that the challenges of workforce are ongoing. We did ask specifically about if there is capacity to take on more services, and all the pharmacists pretty much agree that they have capacity to take on additional, to be commissioned for additional services.
Thank you all. Thank you, Joel and Pooja, again for the work that's gone into this, no vote required today. Obviously, a vote will be required on the 29th of September, and we wait to see the final, I'm going to call it a draft, even though I think it will be, as I said, a fait accompli at that stage, but thank you both. Let's move on. Tracy, back to Professor Daskovitz, and we're going to look at the suicide prevention strategy and, or the suicide prevention strategy, according to the report, but never mind.
Oh gosh, that's not good, is it? It's not good at all. Look at that. So yes, definitely suicide prevention rather than that. That sounds like a very exotic dish. Bringing this back to you, the suicide prevention strategy was actually adopted last autumn, so it's a fairly new document. So it's quite unusual that I'd be coming back to Health Wellbeing Board for your views on updating the document. The reason for doing so is that there is been a policy shift. There's been an awful lot of research and data that's come out on the back of COVID and the impact on the level of deaths by suicide. And there is also a new system that I would like to adopt locally around real-time surveillance. So for this reason, I'd like the opportunity to do an update of the suicide prevention strategy. The other reason for doing so is trying to overlay public health strategy, looking at them from a social, economic and environmental perspective. So looking at root causes of suicide and understanding the triggers and key transition points in people's life where death by suicide becomes more prevalent. So things like loss of jobs, breakdowns of relationships, the loss of a partner. And even in the younger age, we're seeing transition from school stages increasing in terms of suicide attempt and also incidents of self-harm. So the review of the document is to make it broader. And the other aspect that I'd like to introduce would be to hold a suicide prevention summit in the autumn, where we launch the consultation on the refreshed strategy and get greater partner buy-in so that we can deliver suicide prevention across a broader range of policy locally and just to update it more generally. And then with a view for in the spring of next year, we would come back with a final updated strategy for adoption by Health and Wellbeing Board.
Thank you. Before I come to Councillor Masters, I've just got a note. Of course, Gary Paulson's given apologies for this meeting. He has asked us to note that the West Berkshire Suicide Prevention Action Group continues to do all the practical suicide prevention work in West Berks. They have a 1 day per week outreach worker supported by the board of the group, and they continue to provide training courses and 2 courses which will be delivered in the next 6 weeks, one specifically aimed at the racing industry, because there is an issue, which will take place in August. So members and anyone else watching this, please take note. Councillor Masters.
Thank you, Chairman. Thank you, Tracy. Just a quick question. You touched on, the issues around data and also on COVID. Anecdotally, I'm personally experienced 2 people who've been diagnosed with long COVID who've taken their lives over the last 18 months. Is there any data being collected in relation to that specifically? I know you collect a lot of data sets across the whole health and well-being and public health. Is there any specific data for that?
So there is data being gathered around people living with long COVID. It's not being linked directly with suicide prevention. And the challenge around that is, and this is why the real-time surveillance becomes really important in how we can work closely with the coroner's office to understand the cause of the death by suicide, because if we can have more up-to-date data and understand some of the issues that are leading to death by suicide, then hopefully we can put more targeted interventions and support in place for people. The brilliant support that Councillor Bridgeman has just highlighted in terms of the links with the community and some of that training and awareness work that's already going ahead, really maximising on that in our understanding. So it would hope that the real-time surveillance work would enable us to make those links more purposefully and make sure that we've got that information to inform the strategy going forward, and obviously the action plan and resulting interventions as we progress.
Thank you. And Councillor Vickers.
Thank you. Just briefly, I just wanted to draw attention to the comment. It's related to why we're doing this work, and thank you very much for this report, which is obviously extremely important and which we all welcome. But on page 227 and 5, it says that only 28% of people who die by suicide are known to services, which is obviously why this work is really important. And I suppose that highlights the importance of the mental health first aid training, which is promoted, and which hopefully other businesses are taking up, because obviously that is the way that people will be more aware of mental health issues with the people that are around them, and hopefully know when it's crucial and they need to encourage them to be, you know, to take some action or know how to listen to them. So I hope that is something that's addressed here. And along with that, I think at our last meeting, we talked about the problems we've had in getting a representative from business to attend health and wellbeing boards. And that because of this, we had sort of, I think, we'd sort of given up trying for the time being, but I would have thought, particularly in light of this, a lot of people spend a lot of their time at work, and if businesses are engaging, we should try a little bit harder maybe, and maybe, you know, sort of try and point out to them that although they're not responsible for their employees' health totally, although it is part of, the, you know, something they should be considering, that maybe, you know, this is something that would be valuable to have a representative, particularly as regards identifying issues as regards mental health.
Did you want to come back on that, Tracy, before I go to Andrew?
Yes, thank you. Again, another exceptional point, Councillor Vickers, and I think there's several reasons why the workforce point is incredibly well made. We are working in extraordinary ways. You know, I mean, that there are benefits and negatives to our hybrid working, and it is a lot harder for colleagues and managers to pick up on people that may be slipping into low mood, who may not be themselves when you're seeing them in snapshots for an hour or so on a screen in meetings, and we're not having that daily interaction with people. So I think, you know, as employers and colleagues, we have a huge responsibility to ask if people are okay, and to ask again, and to make sure that people have the opportunity to respond and highlight any support that they may do. And whilst we have a number of deaths by suicide by people that are known to services, we also have nationally a number of deaths by suicide for people that have it, you know, it's very sudden, hugely devastating for families, and leaves a lot of unanswered questions. So the greater opportunities we can have to make sure people come forward and seek support. And of course, work is one of our constants. It is a great source of support for people, and people make really good relationships within work. So it is something that I think we can definitely promote as a large employer, to make sure that we've got support systems in place for people to highlight their needs.
Thank you.
And Andrew.
Thank you. I just wanted to again reiterate the excellent work that Gary's committee's done. It really has been a real driver in this. However, I still have concerns that we've got blocks in systems that don't necessarily help with things like this. I'm aware that in past times, things like GDPR issues have stopped people getting help because people weren't able to speak to someone because they didn't have permission with someone standing on a bridge. We've had similar issues with people at high risk attempting suicide. And I wonder whether with real red flag markers like that, if someone potentially attempts something, have we got anything in the system that will perhaps say, look, we really need to wrap some help around that person, so that it hopefully that, you know, the path can be changed rather than it go through. And then I think the other really key thing that we could help drive here is from a sort of work perspective, public health and HSE, every single employee will always do, you know, safeguarding training, equality and diversity training, manual handling training and fire alarm training. Why don't they have to do basic mental health awareness training? Why can't we mandate this, or see whether we can ask as best practice to make, because companies will basically do what they have to. You often end up explaining why they should do it later, and often it is the sort of stick approach. Well, if someone does something and they injure themselves, you could be liable. Well, isn't it really interesting that from a mental health perspective, there isn't that sort of similar feeling? So I wonder whether there's any work could be done there with the LEP, Chambers of Commerce, the local business groups who meet on a regular basis all across Berkshire, West Berkshire and Berkshire West, to sort of say, well, it may be voluntary, but it's really good practice, because the devastation that an event like this can have to you, your firm, your employees. You know, we know the data on once a suicide has happened, the surrounding effects with those affected by it. You know, it's as known a fact, I think, as you could probably get. If it was physical health, you'd say that's an absolute factor. So I just wondered if any of those points can be included in improving this, or if they're already happening, then brilliant. Thanks.
I think, again, I think points incredibly well made, and I think that there is mental health first aid. There's also Connect 5. You know, there are a number of really good models out there that we could do as bite-sized sessions, as ways of raising awareness, that I think people just from a personal interest would get. You know, we've all got friends, we've all got family, that there will be periods of time where people need additional support. So I think bringing these things to the fore of our mind is incredibly important, and every opportunity to do so we should take.
And Councillor Stewart, as one of those, I think possibly all of the members in the room who undertook the first aid mental health, mental health first aid course, let's get it right. Over to you, and the mental health champion, by the way.
Well, yes, and there's just so much to say, and I realise that at this point in time we've got perhaps not the amount of time to talk about things, but I'm very happy to second this paper. And as you say, mental health champion, listening to Andrew, who always has some fantastic things to say, I totally understand what you're saying about a mandate in terms of mental health training, because Councillor Bridgeman mentioned that I worked with officers to help members get access to some mental health first aid training, because I think it's important for us in terms of self-care, but also for our peers, our colleagues, officers that we interact with, our residents, our families. You know, it's never ending. It's interesting that there are, for various reasons, there are individuals who they don't need to access that sort of opportunity. I'm not talking just members, but just in general. And I think that's something that perhaps could be explored more. I find it difficult to understand why somebody would not accept the offer of some more help and assistance in those matters. Mandating it is one that I'd love to be able to do, but of course, in reality, nothing can be mandated 100%. I also I a charity that supports children and families who've been bereaved, and we're hearing a lot more stories and a lot more people coming forward for those services and our support because of death by suicide. And there is a lot of difficult family perspective there. They actually feel embarrassed or uncomfortable about talking about the death of their loved one with others because it's death by suicide. And I think that's a really interesting point. That the families sometimes take on that feeling in that situation, that somehow they're to blame, and I think a lot about, you know, could I have done something to help prevent this? So they don't want that. I think it's I guess the only other question I might have had was around who is invited to the summit you'd like to attend.
Brilliant, thank you. Thanks, Councillor Stewart.
So you heard, hopefully you heard that, because Andrew, you've said that you can't hear.
Yeah, the sound was coming in and out quite dramatically on my feed.
Was that whilst Councillor Stewart was speaking, or?
Yes.
Was it me flapping my hands about?
Right, no, I can see them. So members, as you know, in order to propose anything at a meeting, the proposer and seconder needs to be actually in the room. So I'm sure Tracy would be proposing this were she in the room. She isn't, so I will propose it. We've already heard Councillor Stewart say she'll second it. So everybody who's on this meeting, using Zoom hands, do you approve the recommendations which are at 2 of the paper? Right, I'm going to assume that Andrew's abstaining, as he always does. Fine, Janet, do you want to vote? Stick your hand up if you can't find your Zoom hand. Yeah, precisely. Okay, thank you. That's I think unanimous virtual vote. Right, so members in the room, those in favour say go with hands. Thank you very much. That's unanimous. So those recommendations are approved. Thank you. We move on to GP representation in West Berkshire. Now, Belinda was going to present this, but she's had some travel issues, which is why I'm so very, very thankful that Joe managed to make it to the meeting room and make us quorum. And also, she's drawn the short straw of presenting this paper. Over to Joe.
Thanks, Graham. I've been trying to familiarise myself with the paper during the meeting, but what I'll do is essentially, as it's quite brief, take it as largely read, but just highlight the main points. Sorry? Oh, I don't mind. Yeah, I won't go through in any detail, but just to highlight, I suppose from the first slide, which largely summarises the points I want to make, that there has been a slight drop in GP numbers in Berkshire West and in Bob. We do still benchmark well against our neighbours in the southeast. There is optimism regarding the 25 trainees in Berkshire West. Those are GP trainees, but further thought that we need to take regarding how we ensure that they stay with us in the system, and how we continue to support workforce development. But the couple of points you'll see on the slide in front of you really regarding the additional roles reimbursement scheme. So that is a scheme and a quite large pot of money that comes alongside the primary care networks, and that is used and being used pretty successfully locally to increase numbers of various varying roles which do provide direct patient care. So those are all new people working in practices, providing appointments to patients, taking some of the pressure off GPs and therefore enabling those GPs to work at the top of their licence, which I'm sure is a phrase that the board's familiar with, in order to manage those patients with the most complex sort of health management needs. So while yes, sorry, I wasn't entirely briefed on the background of the reason this has come to the board and if there are any particular concerns, but yeah, just to highlight that although there is some local recruitment and retention issues when it comes to GPs, that overall the primary care workforce is increasing.
Thanks, Joe. I think you're doing a sterling job given the amount of time you've had to prepare for this. Members, I don't know that we can really properly ask Joe any questions. It's because I think that those would be questions for Belinda and for others. But certainly Joe is happy to take any questions you have away. What I would suggest, rather than doing it now, if you have questions that you want to address, send them into Gordon, so Gordon can then pass them on and they can get answered. Thank you, Joe, and can you thank Belinda for the preparation, but we'll make sure that if anyone has any particular issues they want to raise, they do get answers. So, members, next, the final, I think, ever CCG Annual Report. This is simply an item to note. I ask you to note the report that you have been sent. I think if you have any particular items to raise on that, raise it with what was the CCG is now the ICB through whichever angle you want, because this is going to be the place-based partnership and we're still not too certain exactly what that's going to look like. So watch this space on that one. Members' questions, Gordon, I don't think we've had any, but please confirm.
No questions received, Chairman.
Thank you. Members, then the penultimate item is the forward plan, which is in your pack. Does anyone have any question they want to raise about the forward plan? Andrew.
Yeah, I just wanted to do a sort of quick update, Voice of Disability. We've had some preparatory meetings with public health, I have to say, because of staffing issues and various other things with Healthwatch West Berks, we're really going to struggle to give you a meaningful update from our perspective. So I wonder if, sadly, we could move it back to perhaps the December meeting, where we've got a little bit more time to come up with something a bit more worthwhile that both reviews the recommendations, but also in our new post-COVID world, perhaps reflects on the effects that may have had from where the initial report was made.
Well, certainly, and September's looking pretty chunky anyway, so that I think we'd be very happy to move that to December. Anything else anyone wants to pick up? So, members, dates for future meetings, are they in the agenda pack? I'm looking at my note, and you have those dates, so read them. I've already given my apologies in anticipation for the 29th of September, so I will see you all in December. That, I think, then, unless anyone has anything else they're desperate to raise, is it. Look at that. You see, I got it back on track. 11:30. Pure, I can assure you, way more luck than judgment. So, members, if you'd like to stay in the room while we close the virtual meeting and close the stream,